Rank 1. The medical student. You want to be a surgeon. You decide this at 6 a.m. in a hospital corridor during your third year of medical school. You're on the surgery rotation. You're not allowed to touch anything yet. The case is a bowel resection. A section of intestine is diseased and has to come out. The healthy ends get sewn back together. The attending does this through 3 small incisions, a camera, and instruments with hands that have done it 10,000 times. You watch on the monitor above the table. You see the problem. You see it fixed. You don't speak. You don't move. At some point you understand this is what you want to do with your life. You don't know yet what that decision costs. 14 years of training. $300,000 in debt. The hours, the marriages, the people who started this path before you and didn't finish it. Rank 2. The medical student on surgery rotation. You're on the surgical ward at 5 a.m. You got there before everyone else because someone told you that's what you do. You don't know why yet. You will. The surgery rotation is 8 weeks. Scrubbing in means washing your hands for 5 full minutes, following a specific protocol, and entering the OR without touching anything. A retractor is a metal instrument that holds tissue out of the way so the surgeon can see. Your job is to hold it. You hold it for 3 hours without moving. Your arms go numb. You don't move. You are the lowest person in that room. Below the attending, the resident, the nurses. You observe and you stay out of the way. If the attending asks you a question you can't answer, you say so and look it up that night. One afternoon, an attending repairs a hernia, a tear in the abdominal wall where tissue pushes through where it shouldn't. He closes it in 20 minutes. You understand for the first time what it looks like to be completely certain of what your hands are doing. Then a visiting lecture, a man named Dr. Holt, chief of surgery at one of the top general surgery programs in the country. He talks about what the specialty requires. Precise, cold, contemptuous of incomplete commitment. He says most people who think they want surgery don't understand what that means. He doesn't look at you when he says it. You apply to 30 programs. 28 reject you. 2 offer interviews. You travel, wear a suit, answer their questions. 3 months later, match day. You open the envelope. General surgery. Level 1 trauma center. You matched. You're 26. You're $280,000 in debt. The program you matched into is Dr. Holt's. His name is on the door. Everyone congratulates you. A few of them look at you the way people look at someone who just bought a house on a floodplain. Rank 3. The surgical intern. You're making $58,000 a year. You're working up to 100 hours a week. That comes out to about $11 an hour. Less than that some weeks. You are the lowest person in the building. Below the attendings, the residents, the nurses, the surgical technicians. Your job is not to operate. Your job is to check blood results at 4 a.m., fill out discharge paperwork, obtain consent signatures, and hold the camera during laparoscopic cases so the resident can see. Occasionally, at the end of a case, you close the skin. That's it. That's intern year. Every week, there is a meeting called Morbidity and Mortality Conference. Every surgeon in the department sits in a room and reviews every complication from the previous week, every patient who got worse, every mistake, every outcome that wasn't planned. Dr. Holt runs it. He runs it the way a prosecutor runs a courtroom. In your second week, he asks you why a specific lab test was ordered on a patient the night before. You don't know. You weren't involved in that case. He moves on without waiting. The silence is worse than being yelled at. You find the break room afterward. You sit down. A man you've never spoken to sits across from you. He introduces himself, Dr. Marcus Webb, attending at this program for 20 years. He explains the answer to the question Holt asked. No performance, no judgment. He just explains it. He says Holt does that to everyone. The ones who come back the next day are the ones who stay. Then he leaves. You come back the next day. 3 months later, a patient dies overnight. An elderly man, post-operative, a blood clot traveled to his lungs, a pulmonary embolism, and his heart couldn't handle it. You called the attending at 3 a.m. He walked you through every step. The patient died at 6 a.m. You wrote the death note in his chart. You went to see the next patient. You didn't cry. You didn't feel much at all. Webb found you the next morning, asked how you were doing. You said fine. He looked at you for a moment. He didn't push. End of intern year. $290,000 in debt. 27 years old. Year 2 begins. You finally start operating. Rank 4. The junior resident. Year 2. You're finally operating. Your first case as the primary surgeon is a laparoscopic cholecystectomy, a gallbladder removal performed through small incisions using a camera and long instruments. It's the most common operation in general surgery. You've assisted on it 40 times. You know every step. Now the attending hands you the instruments and steps back. You track the anatomy, the camera angle, both instruments, everything that could go wrong. Your attending is at the door, not scrubbed, watching. At some point he leaves. You don't notice until the case is over. 90 minutes. The gallbladder is out. No complications. You feel something. You don't have a name for it. By the end of year 2, you don't feel it anymore. It's just a case. Then the next case. Then the next. Midway through year 3, Holt writes your formal evaluation. It goes into your permanent file and follows you when you apply for fellowship after graduation. His assessment. Technically adequate, questionable judgment under pressure. Recommend close supervision. You have 30 days to contest it. You don't sleep for a week. Webb doesn't ask your permission. He files a written challenge through the department's formal review process, citing your case logs and every other attending's evaluations. 3 weeks later, the assessment is revised to neutral. Your file is clean. He tells you it's handled. He doesn't tell you the details. You don't ask. Holt never mentions the evaluation again. Meanwhile, your partner asks when things will get less intense. You say after residency. You both know that's not what they were asking. Case count at the end of year 3, 400 operations logged. You need 750 to graduate. That's the minimum required by the national body that accredits surgical training programs. You stay late. You take extra calls. You want more cases. The R is the only place you feel like yourself anymore. Year 4 begins. Rank 5. The senior resident. It starts at 6 a.m. in an elective case. Webb is letting you lead. He scrubbed in beside you, but his hands are in his lap. You're removing a section of diseased intestine and reconnecting the healthy ends, the same operation you watched your first day in an OR 4 years ago. Webb guides with almost no words. A small adjustment. A question about your next move. When you answer correctly, he says nothing. Afterward, over coffee, he says, "This is the best it will ever feel." You don't understand what he means. You assume he means residency. 2 nights later, 2 a.m., a trauma activation. Gunshot wound to the abdomen. The attending is 20 minutes away. You are the most senior surgeon in the building. The patient is 22 years old and bleeding into his abdominal cavity. You open him. You find the source. You control the bleeding with packing sterile gauze pressed directly against the injury to slow hemorrhage while the body stabilizes. You make decisions you have never made without supervision. The attending arrives, reviews your work. Good. 1 word. You've spent 5 years waiting for it. It lands almost like nothing. The next morning, your partner says, "I think we both know." You do. You sign the divorce papers in the hospital cafeteria between a morning case and afternoon clinic. You go back upstairs. Board exams. Written first, a full day of questions on managing any surgical emergency. Then oral boards, 2 senior surgeons in a room asking you to manage crises out loud. No notes. These tests certify you are legally qualified to operate without supervision. You study for 3 months. You pass both. Webb meets you for coffee to say congratulations. You notice his hands around the mug. A small tremor there and then gone. He laughs. Says he's tired. You've both always been tired. You let it go. End of year 5. $250,000 in debt. Divorce final. Board eligible. 31 years old. Chief year next. Rank 6. The chief resident. You run the OR schedule. You manage 11 residents below you. You represent the program at departmental meetings. You are the most senior person in training and you are still a trainee. You're operating 4 to 5 days a week. Complex cases, colon resections, liver procedures, bile duct repairs. The volume is the highest of your entire residency. You also handle scheduling conflicts, resident complaints, quality review paperwork. You sleep less than intern year. 6 weeks in, you're performing a hernia repair. A hernia has 2 sides left and right. Before every operation, the team does a timeout. A brief check confirming the patient's name, the procedure, and which side you're operating on. You've done this check 1,000 times. You're tired. You're already thinking about the next case. You're about to make the first incision on the wrong side. The circulating nurse, a woman who has been in that OR for 22 years, says your name. Just your name. You stop. You look at the marking on the patient's skin. You look at the consent form. You verify. You correct it. You finish the case. You perform 2 more cases that afternoon. Holt sits you down the next morning. He says the system worked. That's what systems are for, that you need to manage your fatigue. He is not wrong. You nod. You leave. That night you replay the position of your hand for 3 hours. The program has a mandatory wellness check. A therapist once a year. You go. She uses 3 words: burnout, anxiety, early PTSD markers. PTSD means past events return as if they're happening now. More than 70% of surgical residents, more than 2/3 of everyone in training report feeling this way. Nobody talks about it. You cover for Webb a second time this month. A late arrival to morning conference. An excuse you make on his behalf. You know what's happening. You don't know what to do with it. Chief, year ends. Residency is over. Board eligible. 33 years old. 11 years of training. Fellowship starts in 3 weeks. And there is a decision you have been avoiding about Webb. Rank 7. The fellow. Then the attending. Fellowship is 1 more year at the bottom. Colorectal surgery, diseases of the colon, rectum, and lower intestine. New hospital, new city, new attending, new hierarchy. You've moved 4 times in 10 years. You unpack the same boxes. 3 weeks in, a scrub tech pulls you aside after a case. Webb's hands were unsteady last Tuesday. She saw it. She doesn't know who else to tell. There is a formal process called a physician health program, a confidential system where you report a colleague you believe is impaired alcohol, illness, anything that puts patients at risk. The report triggers an evaluation. If the evaluation confirms a problem, the surgeon's privileges are suspended until they complete treatment. You report him. Anonymously, through the right channels. Webb is suspended pending evaluation. Diagnosed with alcohol dependency. Enters treatment. Surgical privileges suspended indefinitely. He calls you once, about 2 weeks later. He knows it was you. He doesn't say so. He asks how fellowship is going. You talk for 4 minutes. That is the last real conversation you have. You did the right thing. Fellowship ends. First attending job. An academic medical center, your own or days, your name on the operative report as the primary surgeon. The thing you've trained toward for 12 years. Your salary is $380,000. After taxes, malpractice insurance which surgeons pay out of pocket, roughly $15,000 to $30,000 a year licensing fees, and student loan payments, your take-home is real but not transformative. Debt down to $180,000. You're 35. 8 months in, a patient develops a post-operative infection and is readmitted. His family contacts a lawyer. You receive a malpractice notice, a formal legal claim that you caused harm. The hospital's legal team takes over. You are told not to contact the patient. The case settles a year later. You were not negligent. Holt retires. The department holds a ceremony. A named surgical endowment is announced in his honor. 40 years. Everyone stands and applauds. You stand too. You're a surgeon now. A real one. You have no one to tell. Rank 8. The division chief. 10 years as an attending. You're promoted to surgical division chief and residency program director. Fewer or days. More meetings. You are responsible for every surgeon in your division and every resident in your program. You decide who gets in. You decide who stays. You still operate 3 days a week. It's the one part of the job that makes sense. A second-year resident in your program, someone you personally advocated for during the match, makes a serious error during an overnight case. She misses an internal injury. The patient isn't reassessed until morning. By then, the damage is permanent. The family contacts a lawyer. You manage the process. The case is reviewed at Morbidity and Mortality Conference. Documentation is complete. The resident is placed on supervised practice pending a formal review. The legal team handles the family. The program's accreditation is preserved. You did everything correctly. You sit the resident down afterward. You tell her what Webb once told you. That this happens. That the system caught it. That she needs to learn from it and move forward. You watch her face. You don't know if it helps. 3 weeks later, Webb's daughter calls. Cardiac event. He died that morning. He was 61. The funeral is on a Thursday. You speak. You say the right things about the kind of surgeon he was, the kind of teacher he was, what it meant to train under someone who still believed the work was worth doing. You mean all of it. You implement a resident wellness program. Mandatory check-ins, a confidential support line, peer counseling groups. Participation is low. Surgeons don't ask for help. Asking means you can't handle it. Holt built that culture over 40 years. It does not change because of a memo. You're making $420,000 a year. Your debt is gone. Your children are in middle school. They know you're a surgeon the way they know other facts about the world. Not about you, about the world. Rank 9. The retired surgeon. It starts with a tremor. Small, intermittent in your right hand. Your scrub tech notices it before you do. She waits 2 weeks before saying anything. When she does, she chooses her words carefully. You know exactly what it means. You saw it in Webb's hands around a coffee mug when he was 52. You are 57. You set your own retirement date. You don't wait for anyone to suggest it. Your last case is a bowel resection. The same operation you watched your first day in a Nor 35 years ago. You close the fascia, the deep tissue layer beneath the skin, with the same knot you've tied approximately 8,000 times over 28 years. The scrub tech hands you the last suture without being asked. You tie it. You step back. There's a small ceremony. Plaques. A framed photograph of your first or team. A speech from the department chair. You smile. You don't feel what you thought you'd feel. You surrender your surgical privileges, your DEA registration number, your hospital credentials. These are the licenses that allow you to operate. Without them, you are not a surgeon. You are someone who used to be one. The accounting. 28 years. Roughly 8,000 operations. Lives saved you can count, and many more you can't. 3 patients who didn't survive who still visit you at 3 a.m. A pediatric trauma from year 7. A post-operative death you replayed for a year, the wrong side near miss that lives in your hands even now. A therapist gives it a name, PTSD, where past events return as if they're happening now. You thought only soldiers got this. 1 failed marriage, 1 that held. Children who are adults and call on birthdays. Money, time. No idea what to do with either. You think about Webb often now. Somewhere in that hospital, a third-year medical student is on her surgery rotation. She's watching a bowel resection on the laparoscopic monitor. She sees the anatomy appear on the screen. The problem identified. The problem fixed. She decides in that room. She has no idea. The debt. The hours. The marriages. Webb's funeral. The tremor in your hand. But she'll learn. Everyone does.